All right, here we go. We are on chapter 18, cardiac emergencies. So, let's review the cardiovascular system and how it works because it's important to definitely understand how the flow of blood goes through the cardiovascular system. We know that the blood comes in on the right side and then goes to the lungs and then comes back to the heart on the left side from the lungs, and then from there it goes out through the body. And that's how the blood flows through the heart. The other thing you need to remember too is what makes the heart pump, what makes it beat. And that is the conductive system. That's the electrical component of the heart. That's the wiring in the heart. And then what is the blood made up of? Well, the blood is made up of red blood cells, white blood cells, platelets, and plasma. And each of those components have specific things. But the component that carries the oxygen around is the red blood cell. So, and then know how the blood flows through the arteries and veins, and where the actual exchange takes place is in the smallest vein possible, which is the capillary. So, once again, circulation of the blood between the heart and lungs, and then know between the heart and the rest of the body. And then how the heart function and circulation of blood relate to actually generating a pulse and a blood pressure also. And then not getting enough oxygen circulated to the body tissues is something that we call shock. And here's the actual visual picture of a heart and the functions of it. Note the superior vena cava and the inferior vena cava. Both of them empty into the right atrium. And then from the right atrium, they go down through that valve. You see where those little valves are attached to the bottom of the ventricles. But the tricuspid valve, it's called that because it's got three cusps. But the tricuspid valve is what it goes through to get to the right ventricle. And in the right ventricle, the right ventricle squeezes it and pumps it through the pulmonary artery. That's the only artery that carries deoxygenated blood. Arteries go away from the heart, but that artery specifically does not have blood that has any oxygen in it because it's going to the lungs to actually get the oxygen. Once the blood goes to the lungs and picks up oxygen from the alveoli, then it comes back in through the pulmonary vein. And the pulmonary veins are the only veins that have oxygenated blood. Veins go towards the heart, and so generally they don't have oxygen as they're coming back towards the heart. But this one does. So it comes back through the pulmonary vein to the left atrium and down through the mitral or bicuspid valve. And then that has only two cusps. That's why it's a bicuspid. But it goes down to the left ventricle and then out through the aorta to the body. And the aorta is an artery, one of the largest arteries in the body, and it's pumping all the blood out to the entire body. And here it is, where a visual of where it's coming from the body into that number one chamber, which is the right atrium, down through the tricuspid valve into the right ventricle, and then out to the pulmonary artery, and then to the lungs, back through the pulmonary vein to the left atrium, down through the mitral or bicuspid valve into the left ventricle, and then it is pumped out through the aorta to the body. So how does the normal function of the heart and blood vessels relate to blood pressure and distal pulses? Well, the blood pressure is what the heart actually is squeezing and pumping against as it circulates the blood. Our blood pressure can change depending on the size of the vessels that the heart is pumping into. So if our arteries are constricted and made to be smaller or very hardened, such as in a condition called arteriosclerosis, then that heart is going to be pumping against a lot more pressure, and there's going to be a lot more pressure in the system, so they may have a higher blood pressure. If the arteries are very relaxed, then there's not going to be as much blood pressure because the arteries are relaxed and there's more space. Likewise, if there's not enough blood in the system, there won't be a whole lot of pressure either. We can know this by checking distal pulses. Distal pulses are the pulses farthest from our trunk. So the radial pulse might be weak if the blood pressure is low. If the blood pressure is really high, we might have a very strong or bounding pulse. How is shock related to the function of the heart and blood vessels? Well, the heart definitely needs to be pumping to circulate the oxygen around, and those blood vessels need to be holding enough pressure to keep that blood flowing around. Shock is hypoperfusion, not enough oxygen getting to the tissues. So you definitely have to have the blood circulating around in order for it to get to the tissues so that it can oxygenate the cells. So, acute coronary syndrome. This is sometimes called cardiac compromise. That's when our heart isn't working at top notch. So, anytime the heart may not be getting enough oxygen, you might have acute coronary syndrome. The heart is a muscle in itself, and it needs to be oxygenated just like every tissue in our body. And the heart is very sensitive to not getting enough oxygen, and so it'll start to fail and won't pump correctly if the oxygen supply isn't there for it to function. A lot of different kinds of problems can be classified under the acute coronary setting, or ACS. In acute coronary syndromes, there can be other symptoms that can mimic non-cardiac type conditions also. Sometimes people have muscle strains in their chest or respiratory problems. But you want to treat everybody like they have acute coronary syndrome if you see signs and symptoms that appear as if they are. So they have a heart problem until proven otherwise. So what are those symptoms that are acute coronary syndrome like? Well, chest pain is the best known symptom. And usually people that have relate it to cardiac have a crushing, dull, heavy, or squeezing type pain. And it varies in intensity. It may be that it's really, really a lot of pressure and they rate it at a 10. Or maybe it's just a mild discomfort that they don't even want to call a pain. They call it indigestion. If you look at page 494 in your books, you're going to see some of these signs and symptoms that are associated with acute coronary syndrome. That pain and that pressure or discomfort, difficulty breathing, palpitations. Now that's an interesting one. Very seldom do you have somebody say, I'm having palpitations, unless they really know what it is. And you may not know what it is. So palpitations, the best way you can think of it is if you could feel your heart beating, that's a palpitation. So generally we don't feel our own heart as it beats. But if you were feeling your heart beating every little beat, then it's a palpitation. Some other things are sudden onset of sweating and nausea or vomiting, anxiety, feeling of impending doom, unusual generalized weakness, abnormal pulse, either rapid, slow, or irregular, or an abnormal blood pressure. Dyspnea is also found in acute coronary syndrome. That's the difficulty breathing, and sometimes that may be the only finding in some patients. So here's your other symptoms: anxiety, feeling of impending doom, nausea and pain or discomfort in the upper abdomen, sudden onset of sweating, abnormal pulse, fast or slow, abnormal blood pressure. Your patient assessment then. First of all, just like in every patient, perform a primary assessment. You want to find and treat those life threats. Then get a good history, sample history, and a physical exam. Use OPQRST to get a history of present illness. Obtain a past medical history, and take baseline vital signs. Place the patient in the position of comfort. So, what's the position of comfort? Whatever's comfortable for the patient. But typically for somebody having chest pain or even difficulty breathing, it's sitting upright. Determine if oxygen should be administered and then transport. And here's another thought. Let's put some oxygen on them. We only want to put enough oxygen on them to raise the oxygen saturation to 94% or above. So take a look and see how well are they breathing. If they're really having a hard time breathing, they're struggling, and their saturations are not staying up, you may have to put a non-rebreather at high concentrations. Or if it's just mild, maybe they're 91% and all they need is just a little extra oxygen, that's a nasal cannula from 1 to 6 liters. So, how do you manage acute coronary syndrome? If trained, equipped, and authorized to do so, get a 12-lead ECG. And that 12-lead is taking a picture of the heart and where the problem is that the blockage could be, which part of the heart muscle is dying. So that's why we get 12 views of each part of the heart muscle to see which part of the heart muscle is not getting enough oxygen and is dying. And that's the part that the cardiologist wants to go in and open up. So if we get a 12 lead and we fax it or electronically send it directly to the hospital, they can automatically look at it, see what the problem is, and notify their cardiologist so that they can prepare to take that patient straight into the cath lab. So follow your local protocols as to whether this is possible or not, but in the Galesburg system that the Nauvoo Fire Department is in our protocols to do a 12 lead and transmit it. So, indications for administering nitroglycerin: chest pain, history of cardiac problems and prescribed nitroglycerin. A physician has prescribed nitroglycerin to the patient, and the patient has the nitroglycerin with him. So as an EMT, according to the national curriculum, you can assist a patient with their own nitroglycerin for them if they have chest pain. This is a picture of what nitroglycerin looks like. This is the Nitrostat brand, and it's kept in a dark bottle because nitroglycerin is sensitive to light. Sunlight actually breaks it down. It is also sensitive to heat or anything else that can tear it down easily, like warmth, sweat, sunlight. It'll decompose much more quickly. So, when do you want to give nitroglycerin? Nitroglycerin is meant to help dilate the coronary vessels. So it opens up the vessels that are surrounding the heart and feeding the heart oxygen. And what's happened is those vessels have either become clogged or they've become constricted, like smoking constricts them or stress constricts them and causes them to squeeze tighter, and then the blood isn't getting through. Or it could be just a piece of plaque has broken off and gone through that little vessel and blocked it, and now that part of the heart is not getting the blood flow it needs to maintain the oxygen. So what does nitro do? It comes along and it dilates those vessels so the blood flow will go through a little bit easier and hopefully open up and get some more oxygen to that part of the heart before it completely dies. The indications for giving nitroglycerin is making sure that top number, the systolic blood pressure, meets protocol criteria. Generally, it's got to be depending on your protocol, either 90 or 100. So you got to have a good blood pressure because nitroglycerin is going to dilate those vessels and drop the blood pressure. The other thing is make sure that the patient hasn't taken Viagra or any other drug for erectile dysfunction within 48 to 72 hours. Those two drugs, Viagra and nitroglycerin, work together and will drop the blood pressure so far that the patient could actually go into cardiac arrest. So make sure that they don't take Viagra or any other erectile dysfunction drug. And then you need medical direction authorization to give the medication. After giving 1 dose of nitroglycerin, repeat the dose in 5 minutes. If the patient experiences no relief, or if they only have partial relief, so ask them how severe their pain is. Have them rate it from 1 to 10, and then after they take the nitro, see if it's improved. Have them rate it again. If it hasn't, or if it only has improved a little bit and their blood pressure is still good, above 90 or 100 systolic, and the medical director authorizes it, you can give another dose. So, indications for administering aspirin. Aspirin is another drug that you can give to help with the cardiac patient. Aspirin is something that helps to keep the platelets from sticking together. So platelets are activated whenever your blood starts to clot. And if there's an injury inside your vessel, if it's torn or a little bit, or then something called fibrin is activated, which causes the platelets to stick together. So there could be that there's some sort of stickiness going on in the platelets. So what aspirin does is it keeps the platelets from sticking together. Therefore, your blood is going to flow more easily. A lot of people will tell you that aspirin thins the blood. That's not really true. It keeps the blood from sticking together and forming clots. So the other thing to give aspirin, no history of asthma, and if the patient is not taking medications to prevent clotting, such as Plavix or Coumadin, is other drugs that keep the blood from clotting. So to give aspirin, they got to have chest pain, have to not be allergic to aspirin, they have to have no history of asthma, and the patient is not taking medications to prevent clotting already. Make sure they don't have any other contraindications to aspirin. Make sure that they can safely swallow the aspirin, because this is a medication that they're going to chew up and swallow. That chewing activation helps to get it absorbed into the system quickly, and then make sure medical direction authorizes it. Aspirin may be in your protocol. Nitro may be in your protocol. Generally, what we're teaching you in this class is what the National Registry recommends. I will tell you that in the Galesburg protocol for Nauvoo, it is carried on our ambulance. We keep nitroglycerin and we keep aspirin, and those two drugs are administered by standing order protocol. So we don't have to ask for authorization to give it. We can give it the first dose. The subsequent doses after that, we would probably need to ask. Aspirin is just a one-time dose, and the dose is generally 325 milligrams total. We carry it in a children's aspirin, so that would be 4 baby aspirin at 81 milligrams each. So other causes of cardiac conditions. Heart problems caused by a number of disorders affecting the condition and function of blood vessels in heart. So let's talk about those. First, I want to point out one thing about the drugs that we give in cardiac emergencies. I want you to turn to page 498 and 499 in your books, and I want you to review all of the indications, the actions, and the side effects of those drugs. So one of the things I need to point out is a side effect of that nitroglycerin is that it relaxes those blood pressures and drops that blood pressure. So hypotension is a side effect, and people will also get a headache from that, and they may also experience pulse rate changes. All right, so be sure and review that, page 498 and 499. Now let's talk about other heart problems that cause cardiac conditions. There can be conditions that narrow or block the arteries of the heart. This is called coronary artery disease. It's often a result from fatty deposit buildup of the inner walls of the arteries. This also affects their ability to dilate and constrict effectively. But the small vessel diameter of the coronary arteries that surround the heart make it prone to having a problem if you got that plaque buildup in there, and then it restricts the blood flow. A thrombus is an occlusion of blood flow caused by that clot that's forming, that plaque that builds up in the artery itself. It's on the rough inner surface of the diseased artery, and then it builds up. It can break loose sometimes, and if it breaks loose, then that clot is floating around in the blood and can be caught up in other vessels. But we call that, the one that's broken off and floating, we call it an embolism. So a thrombus is a fixed clot. An embolism or an emboli can move around. It breaks off and it floats around in the blood, and it can actually occlude the flow of the blood downstream in a smaller artery. Whatever way that it happens, it reduces blood supply to the myocardial muscle, and it causes an emergency in the majority of cardiac-related medical emergencies. Chest pain is the most common symptom of a reduced blood supply. An aneurysm is another thing that can happen. An aneurysm is a weakened vessel, and it's really serious if it's an aortic aneurysm. So your aorta can have a weakening of the arterial walls, like the inner lining of that vessel. There's 3 linings in a vessel. That inner lining might actually rip or tear, and then the other 2 linings might hold it for a while unless the blood pressure gets to be too great, and then it can actually rupture. A good picture of that is on page 501. So a weakened area happens in the artery, and you look on the top picture there, and it forms a little bubble. Those little weakened areas can actually stretch out and be, sometimes you hear people say they have an aneurysm on their aorta, the part of their aorta that goes through the abdomen, or it can even be up higher, but it'll weaken, and some people will say, well, I have an aneurysm the size of an orange or a grapefruit or a golf ball. That's quite a bit of blood that's being held in that weakened area. When it ruptures, though, the aorta carries all the blood to the body, and so all the blood is circulating through that vessel. That person can bleed out fairly quick. It's an arterial bleed. And if you don't recognize the signs and symptoms of shock, you may not know that they're bleeding out because it's an internal bleeding going on. Here's the picture. This is the same picture that you would see in the book on page 501. It's a weakened area in the wall of an artery. It tends to balloon out and it forms like a sac-like aneurysm. Eventually it can burst. The other thing that can happen is the heart can have an electrical malfunction. The conductive system of the heart isn't functioning. And this can result in an irregular rhythm, a dysrhythmia. Dysrhythmias might include bradycardia or tachycardia and other rhythms that may be present when there's no pulse, such as ventricular fibrillation or asystole. So, what types of things can cause malfunctions of the heart? Well, if your heart muscle is dying from not enough oxygen, the electrical nerves that pass through that area won't function correctly. Three things basically are mechanical malfunctions of the heart. One is angina pectoris. This is just like a heart attack. It's caused by a temporary spasm of the coronary arteries where not enough oxygen is getting to the heart. And generally it's brought on by stress or some type of exertion that the patient is having. And then it can go away if they sit down and they relax and they take a nitro. So angina pectoris is just like a heart attack, but it'll go away if they take measures to relax and maybe even help it with nitroglycerin. An acute myocardial infarction is that blockage of the vessel, coronary vessel, and it can come on in the middle of the night when the patient's asleep. Nothing actually stimulates it. Work can stimulate it, but it'll come on at any time. It's when that artery becomes blocked, and it doesn't go away with rest or nitroglycerin. And then there's congestive heart failure. This number one reason for congestive heart failure on the left side, the left ventricle, is the heart having a heart attack and that part of the muscle dies. And the rest of it is still functioning, it's just not functioning adequately. So as the left ventricle isn't pumping adequately, the blood isn't circulating around and going forward. It's actually backing up in the system a little bit. And if it's in the left ventricle, where is it going to back up to? The lungs. So you're going to see respiratory problems. If it's a right heart failure and it's affecting the right ventricle, then the blood starts backing up through the body and you will see swelling, sacral edema, and even edema in the ankles and feet. And you might even see something called jugular vein distension. The veins in the neck stick out. So, once again, let's review it some more. Angina pectoris. It's chest pain caused by insufficient blood flow to the heart muscle. It's typically due to narrowed arteries, secondary to coronary artery disease. The pain usually comes on during times of increased oxygen demand, such as exertion or stress. An acute myocardial infarction, the straight name for that is a heart attack. It's actually death of a portion of the myocardial muscle from not enough oxygen. Coronary artery disease is usually the underlying reason for that. And here's what's happening in an acute myocardial infarction. See that coronary vessels as they come and surround the heart? Well, the part that's feeding the blue section is blocked. And that blue section of the heart isn't getting oxygen and it's dying. And if you look, that is the left ventricle side. See how thick that wall muscle is? That's thick because it's pumping to the entire body. And if blood backs up in there and isn't moving forward, then you'll start seeing it back up into the lungs. Eventually, it'll back up into the right heart too, because blood isn't going round and round, it's going to keep backing up. But you'll see respiratory signs and symptoms if it's congestive heart failure. So, an acute MI, though, is a part of the heart muscle that's dying. So, congestive heart failure is often a complication of acute MI. It's something that happens because somebody's had a heart attack and part of their heart muscle has died, and now it can't pump adequately. So congestive heart failure in its basic form is inadequate pumping of the heart. What happens then is you get an excessive fluid buildup in the lungs or the body, depending on which ventricle it's affecting. But if it's the left ventricle, then that fluid isn't going to pump forward, it's going to back up. And it's going to back up through the left atrium and to the pulmonary vein and into the lungs themselves. So the capillaries that surround the alveoli have a lot of pressure in them because that blood is backing up. And then the fluid that's in the capillaries will seep out into the lungs, into the alveoli themselves. So what will you see and hear? Well, you'll hear some crackles or rhonchi. You'll hear that fluid in the alveoli as you listen to the lung sounds. And then from there, you will be able to know that, okay, they have congestive heart failure. How are we going to fix it? Well, we're going to do something called CPAP, continuous positive airway pressure. Going to put a little bit of air pressure into their lungs and drive that fluid out of their alveoli and back into the capillaries. So, congestive heart failure is brought on by a diseased heart valve, hypertension, high blood pressure, obstructive pulmonary disease, but the most common complication of it is acute MI. Basically, it's the ventricles not functioning correctly. So, congestive heart failure progresses. It can start out real mild, people that maybe have a little bit of problem. And you'll see this person generally starting to like to sleep, to sit upright to sleep. Helps them to breathe better. They might sleep in recliners. And then they eventually it'll start having more and more problems, and if it's untreated left heart failure, commonly goes into right heart failure also. So the patient will sustain an acute MI, maybe the part of the left ventricle dies because of damage to the left ventricle. Blood backs up into the pulmonary circulation and lungs, and as it progresses, it may even progress to right heart failure, and then you start seeing blood back up throughout their body, like in their feet you have pulmonary edema, or you have swelling of the ankles and you have edema down there, or in their sacral area, their sacrum might have some swelling and some fluid in there also. And then you can also see JVD, jugular vein distension, when it progresses to the right side. Signs and symptoms of congestive heart failure: tachycardia, dyspnea, might be a little bit cyanotic if they're having some respiratory difficulty, normal or elevated blood pressure, diaphoresis. Remember what diaphoresis is, it's sweating. Pulmonary edema is the swelling and the fluid in the lungs. Anxiety or confusion due to hypoxia. Pedal edema, that's swelling in the ankles and feet. Engorged, pulsating neck veins, and that's usually a late sign when you see that JVD. Enlarged liver and spleen with abdominal distension. So, the next thing we want to talk about is the chain of survival. 5 elements to that. Um, and this is strictly review of American Heart Association CPR. You should know this, the most current standards. Five components, five elements of the chain of survival: immediate recognition and activation. The people that usually are responsible for this are the people that see the movie, the cardiac arrest, the bystanders, and recognizing that it's a true emergency and calling 911. And you think, oh, well, how can you not recognize that there's an emergency? Believe me, people do not know when there's an emergency. They convince themselves that, oh, that's not really what's going on. We had a guy that lived here in town years ago, and he doctored up at the VA in Iowa City. And one night, late at night, he wasn't feeling well, so he called his friends to take him to Iowa City, which they did. They took him to Iowa City, and somewhere about Mount Pleasant, they thought that he fell asleep. When they arrived to the VA in Iowa City, he was dead. They did not recognize that what he was having was a true emergency, and therefore they waited too long, and the man died just trying to go to the hospital. Now, appropriate recognition of an emergency, had they known the signs and symptoms of a heart attack, they might have been able to take him to the closest hospital and still have him alive today. So, bystanders, if they're not trained to recognize these signs, if they haven't taken a CPR class, they might not recognize or activate 911. So, immediate recognition and activation is a chain in the link of survival. All of these chains have to work together in order to have optimal patient outcome. The next thing is early CPR. Whether it's bystander CPR, somebody being trained in CPR, or if somebody getting there quickly on an ambulance and starting CPR. So early CPR, and then the next link in the chain is rapid defibrillation. Early CPR and rapid defibrillation is generally the role of an EMT. However, you could be in any number of these roles. Rapid defibrillation is actually what's going to help fix the cardiac problem, the arrhythmia that has generated. And CPR only extends the amount of time you have until a defibrillator gets there. The next link in the chain of survival is effective advanced life support. This is the folks, the paramedics, or even the ER, whichever happens to be closest. They're going to be the ones that are going to be able to prevent the cardiac arrest from happening again. And then integrated post-cardiac arrest care. So taking care of them after they've revived and resuscitated, and actually fixing the problem, opening up the vessel that might be clogged with the cardiologist. This all takes teamwork and coordination, and that's why we practice CPR, and that's why we learn the chain of survival and the links in there. So, another link in the chain of survival: immediate recognition and activation. Recognizing that emergency and notifying the EMS system through calling 911. Early CPR increases survival chances significantly. You can give CPR in three ways: either a trained professional or a lay person is trained in CPR, or you can even have emergency medical dispatchers that are trained to instruct callers how to perform CPR. You want to have high performance CPR. When you're doing CPR, you should constantly be looking and checking and make sure everybody is doing everything appropriately. There have been changes implemented throughout the resuscitation process. There's little things that you can improve on and perfect. Make sure that you're compressing at least 2 inches in an adult. Studies have shown that people are not compressing deep enough when they do CPR. And That makes it so that the blood isn't circulating fully around. The other thing that you need to be aware of is that studies also show that relaxation, allowing the chest to fully recoil in between each compression, is just as important as actually compressing. So it's kind of uh, providing like a suction type, allowing the blood to kind of fill and then relax in the heart like it normally does. So compression and then relaxation. So allow that chest to recoil. Don't take your hands completely off, but make sure that upstroke is fully allowing the chest to recoil. Spend half of each compression on the downstroke and half on the upstroke. Use correct hand placement. And then make sure you're compressing at least 100 times per minute to keep that blood flowing around. Our hearts beat from 60 to 100 times a minute. We need to be on the top end of that amount of times that we're circulating, because we're not circulating as efficiently as our heart when it's pumping on its own. So spend no more than 1 second on each ventilation. Don't overfill those lungs and let that air go into the stomach, or you're going to have stomach distension. Minimize interruptions of CPR, no more than 10 seconds when you interrupt to defibrillate. Make sure you do it quickly. High performance CPR is the key to increasing cardiac output, making sure those compressions are going and keeping that circulation going. Since most cardiac arrests in adults are the result of cardiac problems, not respiratory problems, there is enough oxygen in the bloodstream to maintain metabolic processes for several minutes. So you have a little bit of oxygen in that blood to circulate around if you start CPR as quickly as possible. The sooner the defibrillator arrives, the more likely the patient will survive the cardiac arrest. So, that means that you have a little bit of time to run and call for help. If you see somebody collapse in front of you, run, call 911, come back, start CPR. And then that defibrillator is what's going to help fix the problem. So, rapid defibrillation. And then the next link is the effective advanced life support. Get the paramedics or the closest hospital, whichever is closest. Generally, the ALS is provided by paramedics who respond and they rendezvous with a BLS unit, and then they go en route to the hospital. But if the hospital is closer, there's no sense in sitting there waiting on paramedics. Rapid transport to a hospital may be the one most time-efficient means of obtaining ALS. So, integrating post-cardiac arrest care. When they return and get some circulation, you want to make sure that they're getting care so that they don't go back into a cardiac arrest. So, coordinating numerous means of assessment and interventions that together maximize the chance of a neurologically intact survival. So, you want to maintain adequate oxygenation, avoid over oxygenating them or ventilating them too fast. You want to do a 12 lead EKG if possible, if you have that capability. That way you can identify where the problem in the heart was. The 12 lead takes a picture and tells you which part of the heart muscle is affected. Find and treat any causes of arrest that you can, like if there's a collapsed lung, you can treat that, and if that's the cause of the cardiac arrest. Determine appropriate destination for the patient. You want them to be somewhere where they can monitor a patient that might be that critical. Not all hospitals have that capability. And then possibly induce hypothermia, which is not so much something we do pre-hospital, but it is one thing that studies have shown might help improve neurological outcome in a patient that's been in cardiac arrest. The reason we don't do it EMS wise is because it has to be a specific temperature you actually cool them to. EMTs provide two links in the chain of survival. So as an EMT, the two links that you can as best serve is early CPR and rapid defibrillation. Manage cardiac arrest. Usually there's enough oxygen in the bloodstream to postpone ventilations for several minutes while chest compressions are performed. So as an EMT, perform 1 and 2 rescue or CPR. Wear your gloves. Do standard precautions. Use an AED. You need to request ALS when it's available. Make sure you're using all the links in the chain of survival. Use a bag valve mask device with oxygen, 2-person if possible. Use a flow-restricted oxygen-powered ventilation device if you have access to one of those. Lift and move the patients. Suction the patient's airway, especially keep it clear of vomit and any obstructions. Use airway adjuncts, a nasal airway or an oral airway to keep the tongue out of the way, or even a king airway. Interview bystanders and family members to find out what was the reason of their cardiac arrest, and maybe you can do something to help fix the cause. There's 2 types of AEDs. Typically, we use a semi-automatic. There's semi-automatic AEDs and there's fully automatic ones. I don't know that I've seen a fully automated AED in a lot of years. I'm not even sure they make it anymore. But a semi-automatic one will require the EMT to press a button to deliver the shock. So it says shock advised, charging, and then you press the button to deliver the shock. That makes sure that everybody's out of the way before the shock is delivered. In a fully automatic AED, it does not tell you that the shock is advised. It just automatically charges and delivers the shock automatically. And that is kind of risky because you got to make sure everybody's out of the way if you're going to deliver a shock. Otherwise, a lot of people can get shocked. So there's also 2 types of shock that can be delivered depending on what type of AED you have. You can have a monophasic AED or you can have a biphasic AED. A monophasic AED just delivers a single shock from a negative pad to a positive pad, just right on through. A biphasic one sends a shock in one direction and then back the other. So it more or less analyzes how much energy is actually needed and then shocks at that energy. AEDs work by analyzing cardiac rhythms to determine whether the shock is indicated or not. There are 2 rhythms that the AED will classify as rhythms that it should shock, and that is ventricular tachycardia or ventricular fibrillation. Those 2 rhythms are shockable rhythms. Anything else that it sees when it analyzes a rhythm is non-shockable rhythm. So here's the cardiac arrest treatment sequence, and you'll also be able to find that in your book so that you won't, if you can't read what it says here, then you need to look in your books. And once again, we are on chapter 18, but specifically this chart is on 514. So make sure that the patient is unresponsive, not breathing, and no pulse. Start CPR, turn the AED on, apply the AED and clear the patient, and then press Analyze button, and then it'll talk you through it. Just remember, the first thing you do when you are going to use an AED is turn it on. Once you turn it on, it'll tell you everything else to do. The most common conditions resulting in cardiac arrest are from shockable rhythms. These are the 2 shockable rhythms, ventricular fibrillation and ventricular tachycardia. Coordinate CPR and AED for your patient in cardiac arrest. Don't interrupt CPR unless it's absolutely necessary, and then only for a short period as possible. Now, you do have to pause it to analyze and defibrillate, but most of the defibrillators, the AEDs nowadays, are able to analyze and then shock within about 90 seconds or less, hopefully, or less. Perform a primary assessment. If bystanders are doing CPR when you arrive, have them stop. Verify pulselessness. Verify they're not breathing and there are no other signs of life, and you're going to check for pulse at least 10 seconds. And the pulse that you check in all unresponsive patients is in the neck, the carotid pulse. If they're responsive, check the radial pulse in the wrist, but in cardiac arrest, check in the neck. Apply an AED, bare the patient's chest, quickly shave the area where the pads will be placed. If available, use pediatric pads for pediatric patients. And if you don't have pediatric pads on pediatric patients, you can use adult pads, but don't let them overlap. You cannot use pediatric pads on an adult. Provide CPR while another EMT sets up the AD. Use the AD, you got to turn it on, attach the pads to the cables and then to the patient. Stop CPR and analyze. Clear patient and shock if indicated. So press the button, it's going to deliver a shock. Immediately begin CPR after delivering a shock. Reassess the patient after providing 2 minutes or 5 cycles of CPR. Generally, the defibrillator is going to count down in between the cycles. Perform CPR for 2 minutes. Follow the AED prompts. If an AED finds a non-shockable rhythm, an ECG rhythm that's non-shockable would be something that they call pulseless electrical activity. It looks like a normal rhythm, heart rhythm, but there's no circulation. The most common cause of pulseless electrical activity is there isn't any blood left in the body to pump. So it's probably somebody that's bleeding internally. A systole is an end rhythm. That's when you see on the movie where they're flatlined. That's a systole. And then if the rhythm is one of those two rhythms, you're going to resume CPR. When you provide CPR, compressions shouldn't be interrupted for any longer than 10 seconds. They need to be at least 2 inches deep or at least 1/3 the depth of the chest for infants and children. Make sure that there's full chest recoil. When you provide CPR, the rate should be at least 100 per minute. Rotate personnel through the compressor position because people get tired and after 2 minutes they aren't given effective compressions anymore. If a patient wakes or begins to move, you can stop CPR. You don't need to do CPR if they're starting to wake up. Obtain baseline vital signs, get a good blood pressure, administer high oxygen concentration, and transport. You might still need to bag them with a bag valve mask. So, where did I tell you to check a pulse at? Yes, that's right, in the neck if they're unresponsive. Now, if somebody's doing CPR while you're checking pulse, you actually should feel a pulse.